Today we'll be discussing myopathy, and yesterday we did approach to neuropathy. So in neuropathy, we discussed how neuropathy is an element lesion and presents with weakness, atrophy, hypotonia, and areflexia. We discussed the different nerves in the body. We talked about how to localize a neuropathy lesion, the where, what, and why. We talked about how in every nerve fiber in every nerve there are motor and sensory fibers, and how we can use that to diagnose whether it is a large fiber neuropathy or a small fiber neuropathy. We discussed the difference between a nerve distribution and a dermatomal distribution of involvement. And we discussed the difference between a mononeuropathy, multifocal mononeuropathy, or a polyneuropathy, and the difference between axonal and demyelinating neuropathy. We also talked about how an axonal neuropathy will cause dying back neuropathy, and it can have a glove and stocking presentation. We talked about what are the different types of presentations that can happen, and how by using the anatomical distribution and the physiological distribution. So the anatomical distribution is whether it is a mononeuropathy, polyneuropathy, and the physiological distribution is whether it is axonal or demyelinating. I told you how we can it can help us come to a diagnosis, and I had actually told you to sort of make a list, if you can, on what are the three causes of each one. Now, some of you may have done that, and if so, you can just type in the chat that you have, and at the end of today's clinic, we can discuss that in greater detail. And we talked about how to evaluate it further, which investigations to do, and how to manage it. We talked about positive and negative findings in neuropathy, and we talked about immunosuppression in GBS. So coming to today's clinic, today we are talking about myopathy. So what are the similarities between neuropathy and myopathy, in that both of them are LMN. So all the features of LMN that we discussed in neuropathy will be there in myopathy as well. So that means that there will be weakness, there will be hypotonia, there will be decreased reflexes, atrophy, and fasciculations. Now, out of this, now you have to understand that when we say that LMN has all this is generally true, but there is variations. So for example, in a myopathy, there will be decreased reflexes, but areflexia is not common in a myopathy. If you get areflexia, then you're thinking neuropathy. Areflexia happens in myopathy only at the late stage. So if it is very severe, then you will get areflexia. Similarly, fasciculation is more common in an anterior horn cell disease. Now, in the early stages of myopathy, if there is an inflammatory myopathy, sometimes you can get fasciculations, but if you get fasciculations, you are thinking anterior horn cell kind of lower motor neuron lesion. So these are all variations of this general principle that LMN will come with all these features. The important thing is that if any of this is there, then your diagnosis moves away from upper motor neuron. So that is why it is important to know these. So you are going away from upper motor neuron, but within lower motor neuron, whether it is muscle or whether it is nerve, there you need to know the fine differences. So areflexia is more nerve, fasciculations is more anterior horn cell. Now, coming specifically to myopathy, what is the concept? So we have already spoken about if there is a lesion in the brain, the spinal cord, and the nerves. But finally, the nerve will end up in a nerve terminal, and that nerve terminal will end up in a muscle. So ultimately, any movement that has to happen will happen because one nerve will cause release of acetylcholine, and that will cause skeletal stimulation. All right. So this is the pathophysiology. This is the physiology of movement itself. So any movement that happens in the body ultimately comes down to this. There is a nerve, there is acetylcholine release, and the muscle is stimulated. Now, if there is any problem, so when we are talking of myopathy, we are assuming that your nerve is normal and your neuromuscular junction is normal. So that means that whatever is the problem lies in the muscle. So there are two things that we need to know. One is muscle structure, and second is patterns of involvement. Okay. So let me quickly revise muscle structure. So let's imagine that this is the nerve ending and you have acetylcholine vesicles here. And this is the muscle membrane. Your acetylcholine is released, and this is normal physiology. Okay. So normal physiology of muscle. Your acetylcholine is released. It acts on your postsynaptic, that is your muscle membrane. It will cause sodium influx. It will cause depolarization. This will lead to calcium influx. Your calcium ions will enter into the T tubules. Okay. Now, your muscle structure is something like this. So you have within your muscle fibers, you have actin filaments and you have myosin filaments. And in the middle of your sarcolemma, you have your T tubules. So basically, your calcium channels will enter into your T tubule. It will act on your actin. It will activate the actin, and it will cause the actin to pull itself along the myosin fibers. And so your entire muscle fiber moves. And that is how each individual muscle fiber contracts. So taking a little more zoomed out approach, suppose this is a muscle. Then this will be the tendon. It is attached to the bone. And suppose you take a cross section here. Suppose you cut the muscle here, then you'll get a circular view like this. Okay, and the muscle fibers are going like this. Now, if you look inside the muscle, you can find that there is a covering, outer covering called perimysium. And the perimysium goes inwards. And inside you have smaller coverings called endomysium. And within the endomysium, you have muscle fascicles. And within the muscle fascicles, you have muscle fibers. And within the muscle fibers, you have myofibrils. And this myofibril is what we are seeing here. So each myofibril will contain sarcolemma, and the myofibrils will contain actin and myosin. And that is how the myofibrils will contract, which will cause the muscle fibers to contract, which will cause the fascicles to contract, which will cause the muscles to contract. So roughly that is how the physiology of muscle contraction is. Now, why is this important? So clinically, just like in a nerve, you had to diagnose where is the lesion. And it is not just important to diagnose a neuropathy, it's also important to diagnose which part of the nerve is damaged. So is it the axon? Is it the myelin sheath? Is it the cell body? Similarly, in a muscle, you have to know the anatomy so that you know why the muscle is not contracting. So ultimately, in all myopathies, the problem lies in your muscle not contracting. But we need to know why it's not contracting, because that is what the whole diagnosis is. So you need to know whether is it a sarcolemma problem, is it an actin problem, is it a calcium problem, is it a sodium problem, whether it, in between the muscle fibrils, is there any fat deposition? So these are all different reasons why your muscle fiber does not contract. So just diagnosing myopathy is step one, because that is where is the lesion. But to diagnose what is the lesion, you need to have a brief idea about the muscle anatomy. So that's why I covered this. Now coming to the next part in diagnosis of myopathy is pattern of involvement. Okay. So coming to pattern of involvement, you can essentially have, just like in a case of quadriparesis, if you remember, you had all different forms of involvement. Similarly, in myopathy, you can have involvement of either all four limbs, or you can have involvement of only upper limbs initially and then lower limbs, or lower limbs initially and then upper limbs. But gradually, in most cases of myopathy, with time, all four limbs get involved. You can have involvement of only your proximal part, and your distal part may be spared. So this particular distribution is called as lymph girdle pattern. So your girdles are your shoulder girdles and your hip girdles. So these two patterns of involvement, so just the proximal limb involvement is called limb girdle pattern. And this is actually the most common type. So most of your myopathies are actually present with your limb girdle movement, pattern of involvement. And when I say most of your myopathies, I mean both acquired and hereditary. So we'll discuss this in little more detail later when we discuss the etiology. Now, what other kinds of pattern of involvement can be there? You can have only a distal involvement. Now, this is more rare, but this is called as distal myopathy. And there are a couple of etiologies that can present with distal myopathy, such as inclusion body myositis or something called dysferlinopathy. Now, the names are not very important unless you're doing specialization in neurology or final exam of MD. It's important to just know that myopathies can present with only distal involvement, because typically neuropathies do that. So as we discussed yesterday, glove and stocking pattern of involvement is typically neuropathy, but the difference is neuropathy would also present with sensory loss. So if you have purely distal involvement and there is no sensory loss, you can either think of a pure motor neuropathy, or you should also just think of, could it be myopathy? Okay, so just because it's distal does not mean that myopathy is not possible. Okay. Now, what other patterns of involvement can be there? Now, there may be proximal, there may be proximal arm and distal leg involvement. Now, this is called as scapulohumeral peroneal. So you have the scapula here and your peroneal muscles are here. So scapuloperoneal involvement is your proximal arm and distal leg. Now, again, there are certain specific causes of this pattern of involvement. Uh, just for completion, I'll tell you that if it FSHD, that is facioscapulohumeral dystrophy, Emery Dufresne's muscular dystrophy, and Pompe's disease. Now, these can present with proximal arm and distal leg involvement. The names you can always revise and by heart later. For now, it's just important for you to know that these different patterns of involvement can be there. So what else? What else can be the presentation? There may be eye involvement. So the patient may come with ptosis or ophthalmoplegia. Okay. So there are a couple of specific myopathies that come with ptosis and ophthalmoplegia. For example, mitochondrial and something called as OPMD. This oculopharyngeal muscular dystrophy. So again, just for you to know that a patient may come with limb involvement, or they may also come with just eye involvement, and it could be a part of myopathy. And the other pattern of involvement is your facial involvement. So just your facial muscles being involved is seen in myotonic dystrophy, and again FSHD, because it is facioscapulohumeral dystrophy. Okay, so these are the patterns of involvement that can be there in a myopathy. You have to remember that the most common is a limb girdle type, which is proximal involvement of all four limbs. Now, actually speaking, the where is the lesion has been covered already. So this is actually the shortest discussion on where is the lesion, because in a case of myopathy, to diagnose where is the lesion, all you have to do is to ensure that it is a pure motor involvement, that there is no sensory, and that it is an LMN involvement, and you have to rule out neuropathy and anterior horn cell. So like we discussed in the first point, if reflexes are elicitable, and if it follows one of these patterns of involvement, then you're already diagnosing a case of myopathy. So your where is the lesion has been diagnosed into muscle. Now there are certain things which are supportive. Okay, so what are the things that you will look for in history and examination? So one of them is atrophy or hypertrophy. Now, in an LMN lesion, we have already said that atrophy can be present, but in most myopathies, unless it is chronic, in the early stages, you don't get atrophy, but there are some myopathies that can present with pseudo hypertrophy. So what this means is that there are muscle fibers that are getting damaged and they're actually dying, but they get replaced by fat. So while a normal arm may look like this or a normal leg may look like this, in a case of, for example, say Duchenne muscular dystrophy, you may get extra fat deposition inside your muscle tissue. So the patient may come with huge calves, and it may look like he's been actually working out. So, but there is still weakness. So just because the muscle looks big doesn't mean that the muscle is stronger, but from external appearance, it will seem that the muscle is hypertrophy, but it's not a true hypertrophy, because it's not the fibers themselves that are growing, it is actually fat deposition. So one of them is hypertrophy. The other one is fatigue. Now, fatigue is a non-specific complaint because in almost any element lesion or any chronic disease, the patient may come with fatigue, and you cannot use fatigue to localize the lesion. But if you have fatigue, then it can be a corroborative evidence. So just in myopathy, you can have fatigue. A more specific one is myalgia. So if the patient comes with specific pain over some muscle, then that is a sign that can be used to help localize the lesion. So myopathies that are specifically known to be associated with myalgia, for example, is vitamin D deficiency, which is called osteomyelitic myopathy. A lot of your metabolic myopathies, actually, even your hypothyroid myopathy, can have associated pain, or any inflammatory myopathy. So we'll discuss what are the inflammatory myopathies later along with etiology, but myalgia and pain is important. Another one is cramp. Now cramp is continuous contraction of your muscle fibers, and it is involuntary, and cramp can be a very specific sign of myopathy, because usually you don't get cramps in either neuropathy or in anterior horn cell. You can get cramps in your electrolyte disturbances, but that also ultimately becomes a form of myopathy. So cramping is specific, especially cramping in non or atypical muscles. So usually we get cramps if we get cramps in your calf. But supposing if a patient comes with cramps on the thigh or in the back, then that is a red flag sign. Next is contracture. Now, a chronic neuropathy can also present with contracture, but that is again because of disuse atrophy of the muscle. So contracture is actually a sign of muscle disorder. And last is myotonia. Now, myotonia is an important concept to understand. Basically, what is myotonia? Myotonia is when you voluntarily contract a muscle and keep it sustained for some time. You have trouble relaxing the muscle. So supposing you keep your fist tightly balled up for 10-15 seconds, normally you're able to open it quickly, but in a case of myotonia, you are unable to open it quickly. So there is a very slow and gradual relaxation of whichever muscle has been contracted, and this is myotonia. It's basically due to repeated depolarization of that muscle fiber. So when you are contracting, you're continuously depolarizing that muscle fiber. But in a normal person, that should not be a problem. But in specific myopathies, because of repeated depolarization, the patient has difficulty in relaxation. So which are the conditions that can present with myotonia? So all the disease that has myotonia in the name. So myotonia congenita, or myotonic dystrophy, or even hypothyroidism. Okay. There is also paramyotonia congenita. So anything that has myotonia in the name can present with myotonia. Now, what are the other? So these are the associated features of myopathy that you need to look into. Now, what are the other things that you will focus on when you're doing history and examination? One is age of the patient, or age of onset of illness, and one is family history. Now, this is very important because a lot of hereditary myopathies follow either an autosomal dominant or an autosomal recessive or an X-linked pattern of involvement. And age of onset is important because suppose there are signs of myopathy at birth, versus if birth was normal but the myopathy started in childhood, or if the myopathy started in adulthood, or if it started at an older age, elderly. So this will help us come to a diagnosis much better. So if the patient has signs of myopathy from birth, then it is likely to be like a congenital myopathy. If it presents from childhood, then you have to think of Duchenne muscular dystrophy or a Becker's muscular dystrophy. a lot of your limb girdle muscular dystrophies will present in your adulthood, and also your inflammatory myopathies. So inflammatory myopathy such as polymyositis or dermatomyositis. And older age groups are your inclusion body myositis or your oculopharyngeal muscular dystrophy. Now, just to quickly revise these, inclusion body is the one that I said will present with distal myopathy, and OPMD is the one that I said might present with eye involvement. Okay. So limb girdle muscular dystrophy will obviously present with limb girdle pattern of involvement. And so also your DMD and BMD will also present with limb girdle pattern of involvement. And inflammatory myopathy can present with pain. So what we discussed 5 minutes back, and this put together, you can localize the lesion much better. Now, certain things to look in examination. Of course, you will follow the same pattern of examination. You'll rule out any central cause, and then you'll rule out any spinal. You'll check for your nerves, and finally, when you're examining your muscles, there are certain things such as Gower sign. So a Gower sign is when a patient has difficulty in standing up after coming into sitting position. So once he's sitting and you ask him to stand, a normal person should be able to stand without using his hands. But in a patient with limb girdle pattern of involvement, the patient will be unable to stand, and so he will have to put both hands on the floor and then both hands on his thighs and then get up. So he's basically walking up his own body. So it'll be first on the floor and then on his thighs, and then he will get up. So this is Gower sign. Now in investigations, specific things to look for is your creatine phosphokinase, which is increased in a lot of myopathies. Now, certain myopathies have 5 to 10 times increase. Some myopathies have 2 to 3 times increase. Some of them might only increase 1 or 2 times. And some may be normal. I won't go too much into detail on that. But if your CPK is increased, then the chances of it being a myopathy are more, because CPK is not likely to increase if it's a neuropathy or an anterior horn cell. Second is an electromyography. So in an electromyography, what happens is this is a muscle, and your muscle is damaged, for example. So what we do is that we put in a needle and we get the muscle to contract. So in a normal patient, there are certain electric readings that we get, but in a diseased muscle, you will get abnormal readings. So your normal muscle firing pattern will be decreased, and you will get a small myopathic kind of EMG reading. So an EMG is very, very useful to confirm that it is a myopathy. And along with EMG, we also do a nerve conduction study, because this is to rule out whether there is any associated motor nerve involvement. Because as we discussed yesterday, if there is a primary motor nerve involvement, because of secondary muscle damage, you can have secondary myopathic changes. So it's always important to rule out whether it is a motor neuropathy or a primary muscle disorder. And finally, the tests that you can do is you can do a muscle biopsy and put it under microscope and see if is the muscle fiber okay, or is there inflammatory cells in the muscle fibers, is there fat deposition in the muscle fibers. So a biopsy is very useful, and you can do immunology. So immunology for your inflammatory myopathy. So you can do a anti-MI2, for example. And coming to evaluation, of etiology. So all the things that we discussed so far is to first confirm that it is myopathy, find out the pattern of involvement, and then try and come to a diagnosis of why this myopathy has happened. So what can be the different causes? We'll again follow the same vitamins rule. So you can have a vascular cause. So that means there could be ischemic damage to the muscle. Infective. So there are certain infections, like certain parasitic infections, that can cause myopathy. Cysticercosis can cause myopathy. HIV can cause myopathy. Traumatic injury to the muscle can happen. Autoimmune causes such as inflammatory myopathy. So inflammatory myopathy is polymyositis and dermatomyositis and inclusion body myositis. In this, just like we discussed yesterday in a case of GBS, your body's own immune system is acting against your body's own cells. So yesterday that immune system was acting against the myelin sheath, and today the immune system is acting against the muscle fibers. So inflammatory myopathy, in this case, unlike GBS, in this case, steroids is quite helpful. Then you have metabolic, such as your thyroid and your vitamin D. You have iatrogenic. So iatrogenic is drug induced. So for example, statins. In today's times, statin induced myopathy is probably one of the more common drug induced myopathy. Nutritional deficiency. So vitamin D can be here as a nutritional deficiency, and syndromic. So syndromic is your hereditary myopathy. So all your limb girdle muscular dystrophies and acid maltase deficiency, all your glycogen storage disorders, all of them can come as muscle involvement. And I think that's it. So myopathies, if you are looking at it as an overview, myopathy is very simple. If you go in deep, myopathy can get complicated because there are over 50-60 types of different muscular dystrophies, and knowing each one and its specific characteristics can get a little confusing. But for an initial discussion, I think this much is sufficient for you to diagnose that it is a myopathy, and rule out any other causes, and come to a general idea as to what can be the cause. And like every day, the treatment will obviously depend completely on the cause, whether they require antibiotics for infective, immunosuppression for an inflammatory myopathy, or thyroid or vitamin D supplementation for nutritional myopathy. And I think that covers it for today. Now we have around 15 minutes actually. So any questions that you want to ask about today or yesterday, we can talk. And if you have made a list of those different kinds of neuropathy causes, then we can discuss that also. I'll just unmute everyone. And you can use the chat room, or you can directly ask me. Can neuropathy causing secondary myopathic changes cause raised CPK? So that's a good question, and no, not so much, because raised CPK is a sign of muscle damage, but neuropathy causing secondary myopathy happens very gradually, and the damage is never so much that your CPK raises too high. So there can be a mild increase, but suppose there is a 3 to 5 times increase in CPK, then very unlikely that it is because of neuropathy. Okay. Any other questions? Did anybody make that list yesterday? Okay. Oh, okay. Ashi did. Good. Full marks to Ashi. Oh, and Bhavesh. All right. So, what did you read? Let me open that page. All right. So, couldn't find all the examples for mononeuropathy. All right. Uh, so, okay. So let me just show you. I think I have. Hang on. Mm, I have it here somewhere. Oh, all right. So there you go. So you can just, if you want, you can just take a photograph of this screen, and multifocal is axonal, correct, and demyelinating is CIDP and hereditary neuropathy. Correct, Bhavesh, you're absolutely right. So this is the overall flow chart. So this is from I had taken this from one of the journals, but I really like this because it is very it gives you a very clear idea, and you can add whatever. So it's not comprehensive, okay? So it doesn't cover everything, doesn't cover every single differential diagnosis, but it gives you a nice flow chart, and whatever else you find, you can always add on top of this. Okay, so this is the rough picture of if it is a mononeuropathy, and if or whether it is a multifocal neuropathy or a peripheral neuropathy. Now, if it's a peripheral neuropathy and if it is axonal versus, sorry, the demyelinating part is over here. So peripheral neuropathy, polyneuropathy, and if it is demyelinating, then what can be the causes? So I don't think anyone would actually need to go in so deep. This is theoretical unless you are a neurologist and you are getting cases which are very specifically neuropathy, and it is not obviously diabetes, because diabetic neuropathy will be the commonest neuropathy that we all get to see. So this is theoretical. So you can remember this, of course, if you are interested. But more important is the initial part. The is it a mononeuropathy, multifocal mononeuropathy, or a polyneuropathy? If you can come till there and axonal versus demyelinating, then that is more than enough. All right, everybody got it? So, what else? Anything else you want me to discuss? So, tomorrow we'll be doing something non-clinical. Okay, we'll be taking a discussion on memory, and we'll be talking about how we learn, how we remember, and what are the neural networks involved in memory. Okay, and there will be some, it's 90% is neuroscience, but the thing with neuroscience and memory is that it overlaps quite a bit with philosophy, and this is a so for me, I'm quite interested in that overlap between neuroscience and all the other fields. So tomorrow we'll be discussing that. We'll be discussing memory, and next Sunday we'll be discussing music. So we'll be discussing on how the brain listens to music and what happens to the brain when we listen to music. All right, so a couple of questions. Can you discuss a bit about diabetic amyotrophy? All right, and wanted to confirm if Fabry's is Fabry's is axonal, uh, and diabetic amyotrophy. Yeah, sure. Okay. So uh, the basic concept of diabetic amyotrophy is that diabetes does not um, harm the muscle itself, but uh, diabetic amyotrophy is a subsection of diabetic neuropathy. But in your body, diabetes can basically cause like I think 5 or 6 different types of neuropathy. So you can have a distal sensory, you can have a motor, you can have a sensory motor, you can have thoracic radiculopathy, or you can have amyotrophy. So amyotrophy is basically when your proximal lower limbs are involved and you have pain over thighs, pain and atrophy, and it is basically because of your proximal nerve involvement. Okay, so diabetes affecting your proximal lumbar nerves, leading to secondary uh, proximal lower limb involvement, is diabetic amyotrophy. It is gradual, it is progressive, extremely painful, can lead to weakness, and treatment is only diabetes control. Okay, anything else? Is that it? If that's all, then cool. So then I'll see you guys tomorrow if you're attending the memory class. I'll also be giving some neurology based tips on how we can remember. So that might be useful for all the students. And on Monday we'll discuss cerebellum. All right. Chalo. I'll see you guys. Bye. Take care.